Hi everyone, welcome. We will wait a bit more, just a bit more, so people can access to the webinar, and then we start. Okay, so let's go. And so hello everyone, and welcome to this webinar, Mechanical Insufflation Exsufflation Beyond the Device. I am Marius Lebret. I'm a respiratory physiotherapist working at ALMS in the MedLab, and I am delighted to welcome Charlotte Massey, specialist neuromuscular physiotherapist in the UK and also a PhD student. And Charlotte will be our speaker for this evening. Hello Charlotte, how are you?
Hi Marius, thank you for the introduction. I'm good, thank you. How are you?
I'm good, thanks. Thank you very much. So we will have approximately 45-50 minutes of presentation. So please feel free to ask all your questions in the chat at the bottom right. Charlotte will address these questions for about 10-15 minutes after the presentation. Charlotte, if you are ready, I will hand over to you.
Great, thank you. I'm hoping the presentation will come up on the screen now. Okay, I can't, oh, there we go. Great. Hi everybody, my name's Charlotte. I'm, as Marius said, a neuromuscular respiratory physiotherapist based in the UK. And I'm currently undertaking my PhD looking at cough and secretion management in motor neuron disease or ALS. I've worked for many years in the Neuromuscular Complex Care Centre, which is based at University College Hospital in London. I'm currently in Sheffield, which is in the north of England, completing my PhD. So today we're going to cover the following things. I'm going to base this talk around airway clearance in neuromuscular disease. We're going to talk about the complexity of airway clearance in neuromuscular disease. I really want to touch on what patients and caregivers think about airway clearance and use of cough assists. We're going to talk about what to think about when considering an MIE or a cough assist device and all the little things we have to consider as therapists and clinicians when we're thinking about prescribing one. And then we're going to touch on how we can improve our practice to make sure that the right people are getting these devices at the right time. So I really like this quote, which talks about complexity being a dynamic and constantly emerging set of processes and objects that not only interact with each other, but come to be defined by those interactions. And when we're thinking about neuromuscular diseases, we firstly have to consider the conditions themselves. We can't lump them all together. We have to think about access, so access to specialist care. So how are people going to get these cough assist devices? Also, access to equipment, and we're not only talking about the device here and accessing that, we're talking about people being able to access consumables for the devices and also those other things that might be necessary alongside the device, for example, a suction machine. We also need to think about what evidence is available for us in this area. And many of the current guidelines or evidence that's out there are based on consensus statements. And I'll touch on this in a bit more detail. We also often have numerous healthcare professionals involved in care. And I'm speaking from the perspective of the UK, where we have a nationalised health service, but I'm sure it's the same in many other countries, that it's often not just the physiotherapist who's involved in the airway clearance. They may be the one that prescribes the device, but there's lots of other healthcare professionals that are involved to ensure that that patient can use the device. We need to think about the equity of commissioning of services, and definitely in the UK, this is an issue. So not all services are commissioned the same, and some people have access to certain care which other people don't have access. And really importantly in this patient group is access to care support. Many of these people living with neuromuscular disease can't complete their cough assist or airway clearance techniques independently and need either a paid or informal caregiver to support them with this. And then, as I touched on, we have communication across the care pathway and all the different healthcare professionals who are involved. So thinking about the spectrum of neuromuscular disorders, we've got disorders of the nerve. So that is disorders like Guillain-Barré syndrome, Charcot-Marie-Tooth. We've got disorders of the muscle. They're conditions such as Duchenne muscular dystrophy or myotonic dystrophy. We've got anterior horn cell disorders, so things like motor neuron disease or ALS and spinal muscular atrophy. And then we've also got disorders of the neuromuscular junction, such as myasthenia gravis. So all these conditions have a different mechanism of action, and we can't lump them all together and just consider neuromuscular disease as one. There's lots of differences between them, and we have to really assess what it is that makes that person need that device. We also have to consider that there are often numerous factors involved, such as cardiac involvement, in some conditions cognitive involvement, involvement of the gastrointestinal tract and swallowing problems. So these are not just patients with respiratory problems, they have lots of other things going on. And as I just touched upon, we have to consider the musculoskeletal involvement, which means that often they can't hold the mask on independently, they can't turn the machine on independently. And another thing to consider in this patient cohort is the landscape of this is changing due to disease-modifying therapies. For example, what we're seeing in SMA with Spinraza and Risdiplam, and we're going to start to see different disease profiles, and people are going to live longer with these conditions, which is going to put increased pressure on services providing cough assists and airway clearance. Oh, sorry, I went too quickly there. So we have to think about access to airway clearance. So how are people going to be able to access these devices to support them? And access to most services that provide cough assists come from specialist respiratory centres. And sometimes some areas don't have these specialist respiratory centres. Or often, I mean, especially in the UK, these specialist respiratory centres sit in large cities, which are difficult to access if you are physically disabled. Then we have to think about access to equipment. As I touched upon, not all services are commissioned equally, and sometimes people find it easy to access the cough assist, but actually very difficult to access the ongoing consumable items such as the mask and the tubing that come with it. And I'll talk about this later on, but this was something that patients and caregivers highlighted as really important. They really needed to know how to clean the device and get access to these consumables as they were using it. And access to carers. So the ability for the person to complete the airway clearance is often reliant on a caregiver. So one thing we need to ensure as healthcare professionals is that we're providing adequate training so that carers are competent and confident to complete the cough assist or the airway clearance technique independently on a day-to-day basis at home. So I mentioned evidence and guidelines. So here are a few of the care recommendations and state-of-the-art reviews and some guidelines that exist within neuromuscular disease. And as you can see by looking at them, many of them are consensus statements or state-of-the-art reviews. We have very little high-quality randomized control trial evidence for the use of airway clearance in neuromuscular disease. And I'm talking about specific treatments here. So as clinicians, it's often very difficult for us to know what setting should we be putting them on? How often should we be recommending that the patient uses this? Because we don't have that evidence behind us. Now, it could be argued now that completing a randomized control trial in this area may be a little bit sketchy ethically. given that we would find it very difficult to say we're not going to give a certain cohort of patients a cough assist. For example, we would find it very difficult to say in a group of patients with Duchenne muscular dystrophy, we're going to give some a cough assist and some not a cough assist. So maybe we need to think about how we're doing research in this area. And should we be considering using things like behaviour change interventions to support use of airway clearance and support training and skill acquisition of both healthcare professionals and carers and patients to be able to embed the airway clearance and cough assist manoeuvres in their daily lives? And then we have to think about the healthcare professionals' role and responsibilities. So I recently completed some focus groups as part of my PhD project, and this was highlighted as a real issue in that often healthcare professionals didn't know where their roles and responsibilities started and ended when we're thinking about cough and secretion management in people with neuromuscular disease. So there are often numerous healthcare professionals involved, and they all have a unique role. But there is this shared responsibility for patient care, and we really have to consider how this is communicated. Maybe in the future, we have to consider how we can use technology to support this, to make sure that everybody knows their roles and responsibilities and care is getting communicated effectively. So what does current practice look like in the UK? And I've just put one word up there, which is variable. So I completed a survey as part of my PhD project, and this was for any healthcare professionals managing cough and secretion problems for people with motor neuron disease, or ALS, in the UK. And so the aim of the survey was to find out how cough and secretion management practice in MND care was currently. And I'm aware this is just data from the UK. But I'm going to focus this particular slide on confidence. So we asked healthcare professionals about their confidence in performing both assessment of cough and then implementing a treatment strategy afterwards. The colours down there in the key, so red is novice, so that is they don't know about it at all, never heard of it. The darker kind of red there is knows about, so that's someone that's heard of it, but they don't do it themselves. Orange is knows how, so this is somebody who can do it, but they may need support of another person. Yellow is independent. Light green is master, so somebody who maybe supervises others to do this task. And then green is expert, so this is somebody who's expert within the UK in doing this. And then the blue at the top is not part of my job. And we can see when we look at assessment that actually the majority of people are independent master or expert when it comes to doing things like taking a history, listening to the cough, and interestingly for me, considering the impact of bulbar impairment on the cough. When we think about things like a peak cough flow and spirometry, people are a little less confident doing that. But when we compare that to implementing treatment strategies, we can see that implementing treatment strategies such as LVR bag or additional airway clearance devices, so things like the vest, people are really underconfident. So actually what we need to do is we need to ensure that people are confident to complete the assessment, and then they're confident to implement those treatment strategies. And I think that's something that's going to be ongoing. There's further data to come out of this survey, which looks at whether people's confidence correlates with their exposure, so how often they're having to complete a task. So really importantly, what do patient and caregivers think? So I've got a few articles that I'm going to talk through now, which are qualitative research that have asked patients and caregivers what they think. And we know that introduction and process of incorporating a new device can be a disruptive experience. It's then followed by this kind of renegotiation of this new personal and social equilibrium. And it's this modification of these existing coping mechanisms, the strategies, and then the patient and the caregiver need to adjust to this new thing that's in their life. So this study in 2013, they completed semi-structured interviews with people with MND or ALS and their caregivers. And they identified these 4 main themes. So the first one is trust and confidence. So patients felt they needed to have confidence with the machine, and they had to have a trustful relationship between the patient and the caregiver. People with MND had to have confidence in that person doing the procedure with them, whether that be a paid carer or a loved one that was doing it. And professionals highlighted that their confidence in the machine when training patients and caregivers on it was really important, and that the lack of skills could lead to anxiety completing the caugh assist procedure. And different patients could have different experiences with different caregivers depending on their confidence. And there was it was noted that a lack of continuity, so having different caregivers providing it, led to reduced confidence with patients, caregivers, and healthcare professionals. And one thing that they really highlighted for this trust and confidence was that good communication was essential for successful caugh assist. And this is something I've done interviews with people with MND as part of my PhD project. And this is definitely something that they've all noted, that this communication and trust between the patient and the caregiver is really important. Secondly, learning to use the device. So sufficient instructions and time for training were necessary for successful use. And I don't think that's rocket science. I think that's something that we all expect. People who had a loved one as a caregiver felt their training was good, but where there were numerous formal caregivers or paid caregivers, this was described as lacking. So caregivers wanted this thorough training, including, and really importantly, what to do if something went wrong. Also, patients reported that they needed to adjust to this new machine and accept it. And family and professional carers wanted different things from training. So some wanted it in groups and some wanted this individual training and feedback. So one thing for us to get from that as healthcare professionals is that actually we need to adapt our training to suit the patient. And sometimes for us, we know how to use the device. We need to remember that this person and their caregiver is seeing this device for often the first time. Individualized use of MIE was number 3. And what they found from the interviews was that some used it daily and some used it when required only. Some used it irregularly because they struggled to find consistent, competent carers. And this is definitely something that I've noticed in my practice. So, we have to adapt the use of the MIE to suit that patient, and things might change depending on what caregiver availability they've got at that time. And then the perceived effects of MIE. So some reported the device helped clear secretions and help them breathe more easier. But interestingly, some of the Bulbar patients, and we must remember this research was done back in 2013 before much of this Bulbar research came out, reported that there were no perceived benefits. Some patients also reported discomfort in knowing there was something there to help them with secretion clearance if they needed it. So almost like this comfort blanket. So I think the key points for us from this are that MIE can change the relationship and the dynamics between the patients and the caregivers. And we really need to consider how we're giving this training and who we're giving it to. So here are a couple of really good quotes that I picked out from this article. So one person said, "No, I think it has to do with trust because he is more insecure when others are coming, not those who use it. Everyone can learn to use the machine, but he doesn't feel confident when there are new people coming in." Someone else noted, "There can be situations where you have to do some improvisation and you need a deeper understanding beyond that button should be set on too. It's not very complicated either. I think that will be important." So this is really highlighting that patients want to know what to do if something goes wrong. And then lastly, this is kind of going to this comfort blanket. "It helps me with things I can't do anymore." At the same time, that means I've become worse. So considering the psychological impact when you're giving the patient this device is really important. So this is a small study that happened in the UK. So this is just a conference abstract. So there's a little less data from this. But this was a group in the UK who did 7 qualitative interviews with people with MND. And they identified 5 main themes, which are pretty similar to things we've just talked about. So there were a mix of people who were new to MIE, but also some people who'd been established on it for a more significant period of time. And they found that the perception of the MIE is not fixed. So this can change as the disease progresses. So maybe how the person sees the use of the caugh assist will change as the disease progresses. They talked about factors that impact on MIE efficacy, and these can change as the disease changes. So things like the upper airway, saliva and secretions, which we're going to talk about in a bit more detail as we go through. They talked about this multifaceted impact of MIE, and this is what we were just talking about above. So on patients and caregivers, and they talked about this feeling of peace of mind if the MIE is there, and this feeling of control. So having it there means they feel in control. And they talked about the facilitators of usage. So things we've just discussed: education and training, skill acquisition, and barriers to usage. So upper limb function and availability of caregivers. So there were some really nice quotes that came out of this. So this is somebody talking about the caugh assist. I did not know what it was all about the first time. I hated it because there was this big drawing power and there was no escaping it. And it frightened me half to death the second time. And then this is someone talking about their peace of mind. So peace of mind that if you do have secretions, you will be able to do something about it independently without needing medical assistance. So moving on, this was a study done in Australia in 2016. So they did qualitative interviews with children, their parents and PTs. So the first studies we've talked about were adults, and now we're talking about children. And they wanted to identify barriers to MIE use, essentially. So the aims were to gain this insight into the children's, parents and PTs' experience, and also impact on their perceived quality of life. They used a qualitative case study methodology, and they collected the data in semi-structured interviews. So the barriers they found here were child resistance, the child resisting it, time to complete it, and I've highlighted practitioner support here. So I think this is really key, and fear of pressure trauma. So many of the parents noted that respiratory function actually wasn't a main concern in their life unless their child was unwell, which goes back to those themes we've just talked about, that people feel they have this comfort blanket if the machine is there, even if they don't use it every day. All of the parents reported that they felt the caugh assist delivered immediate physical benefits, and they felt it supported their child to be at home and reduce hospitalization. But they did all report that using the device was tiring for the child. However, they did describe how the caugh assist had decreased their fears of chest infection. The barriers to adherence were identified as these kind of, as we've just said, child resistance, time, practitioner support, and fear of pressure trauma. Disruption in the initial stage of implementing a new regime, they felt really impacted. So they described this inconsistent practitioner support and negativity about the device by doctors when their child was admitted to hospital can impact them using it. The authors felt that consistency of information, support, and appropriate using in early stages and support in the early stages was vital to promote adherence to the device. So what do we need to consider then when we are thinking about whether somebody needs a caugh assist device? The first question we have to ask ourselves is, do they need this device? And this is a big question, and it links back to your assessment. We then have to think what we consider when we're choosing settings. Can they use the device independently? What is their care support network? And how will this fit into their day-to-day life? We've just heard from these previous studies that this is really important. And then how will I ensure as the clinician that they have the skills to be able to use the device? So there is no point issuing somebody with a cough assist if it is going to sit in the corner and they do not know how to use it. So firstly, does this person need a cough assist device? So if we have a look, and these are probably quite small on the screen, I apologize, but these are some of the kind of flow diagrams or things that are used currently to decide whether somebody needs a cough assist device. And mostly we're thinking about somebody's peak cough flow when we're considering whether they need a cough assist device. And we're considering whether it's dropping below kind of 270 initially, and then about 180, 170 litres a minute. And what we have to consider is the peak cough flow is one important aspect, but we need to think about, does their airway clearance plan need to be multifaceted? What else do we need to consider apart from the peak cough flow? We need to think about whether it's a primary respiratory problem or is there bulbar impairment as well, because we know that a cough assist device may be less effective with people with bulbar impairment, and we have to consider the settings. We also need to think, when people have got bulbar impairment, about the other things that are going to impact things like saliva and secretion management. So I think I really like this kind of, what would you call it? It's a really easy way to consider when you're thinking about somebody who's got secretions. So this came from a recent review last year by Gisman et al. And they talk about these kind of 4 things that you're considering when you're thinking about secretion management. And so firstly, what is being cleared? So what are we trying to help this person clear? Is it secretions from their lungs? Is it saliva in their mouth? And, you know, what exactly is it that is being cleared? Where are the secretions? Are the secretions in the mouth? If they're in the mouth, probably a cough assist is not the best thing. However, if they're down in their lungs, then that may well be the right thing. And then really importantly, where did it come from and what caused it? And I'm going to talk in a little bit more detail as we go on, how things like poor saliva management and poor swallowing or dysphagia management can impact airway clearance. So we really need to be clear what's causing it, because we need to be treating the root cause as well as providing the cough assist or the airway clearance technique. And then what are this patient's specific airway clearance limitations, and how is that cough assist going to help that? So what can the cough assist do, and how can it support their current airway clearance limitations? So we need to think about cough assist settings and the impact of the upper airway on cough assist settings is something that's been extensively looked into over the last few years. And I could have written loads of studies down there, but I've just picked out 2 here. And probably the first one to come out was Tina Anderson's discussion article in 2017. And what she did was she looked at people with ALS and healthy controls, and she did a nase endoscope and looked down and looked at what was going on in their airway when the cough assist was on. And what she found was that there were significant differences between people with ALS and healthy controls around true vocal fold adduction subsequent to initial abduction during both insufflation and exsufflation. There were also differences between people with ALS dependent on whether they had bulbar flaccidity versus spasticity. In those with flaccidity, so weakness, esophageal opening was noted, so air was going into the stomach, and hypopharyngeal obstructions were more apparent in those with flaccidity. However, in those people with spasticity, laryngeal adduction occurred at the glottic level, so slightly higher, at higher pressures. And they discussed and thought, is this positive pressure stimulating a reflex and causing hyperreflexivity? But this is really important information for us to know as clinicians who are prescribing cough assists. We need to understand what's going on in the upper airway, because that will help us target our settings. And they helpfully provided us with a little flow diagram, which I've put here, to consider if people have bulbar symptoms. So things like ensuring they're triggering on insufflation, decreasing the inspiratory flow to try and reduce these hyperreflexivity, decreasing the inspiratory pressure, and increasing the inspiratory rise time, so the amount of time that the person is breathing in for. They suggest trying these first and then considering laryngoscopy to see what's going on in the upper airway. However, it must be noted that, laryngoscopy or nasendoscopy is an invasive procedure. It involves having a camera put up your nose, and it needs a specialist equipment, which is expensive, and specialist knowledge. So it's not possible everywhere. But what they have done is got us to really think about what settings we're putting the cough assist on for these people that have bulbar impairment. So what else do we need to consider? So we know in many conditions, so ALS, we can see it in myotonic dystrophy, we can see it in spinal muscular atrophy, that many of these people can have excess saliva. And we know that excess saliva can impact on the effectiveness of non-invasive ventilation because people cannot use it, or it's pushing their saliva down into their airways. And we know that saliva management can directly impact pulmonary secretions. If somebody's continuously aspirating their saliva, they're much more likely to have pulmonary secretions. And the evidence for saliva and secretion management, particularly in ALS, is really poor. A recent Cochrane review done in 2022 highlighted that actually there's very, very few RCTs or high quality evidence to tell us what to do. And in these images that I've got here, we can see that this is a patient with myotonic dystrophy who has got pooled, watery, salivary secretions in his pharynx here. And these are just dripping down into his airway, and he's continuously aspirating his saliva. We have to consider what would happen if we put a cough assist on him. Are we at risk of pushing that saliva down into his throat? And what do we need to do to be able to support him to be able to use a cough assist? On the opposite side, we've got this patient down here who's a patient with ALS. He's got really, really thick, tenacious secretions here that are stopping him from being able to use his ventilator. So we have to consider, what can MIE support with this? Can we clear these secretions out of his airway? Or are we going to risk pushing them down? And sometimes that's a really difficult question to ask. So we also need to consider dysphagia. So there's a lot of recent research coming out discussing the link between swallowing and cough clearance. And I think I'm a huge advocate for working really closely with our speech and language therapy colleagues to understand what's going on in the upper airway when we're thinking about swallow. And this is a case study that I'm going to present now that was done in the UK and shows that dysphagia can impact the efficacy and possible complications of airway clearance. So the image that you see on the top is a young patient with myotonic dystrophy, and he's eaten a banana. And this was taken an hour after he's eaten the banana. And you can see the banana is still sat, that yellow bit, still sat there in his pharynx. This patient came in 6 months before, had an increased number of chest infections. His peak cough flow was really low, and physiotherapist thought, let's give him a cough assist. That's going to help him. His peak cough flow is low. He's finding it difficult to clear his chest. He's had lots of chest infections. He came back 6 months later saying, oh, I've had way more chest infections since you gave me the cough assist, and I've been admitted to hospital. And everybody thought, well, I'm not sure where that would be. It looks like it's working effectively. We're getting a good peak cough flow on the device. And actually, when it was looked at under video fluoroscopy, which is the image there, because the patient was sitting with food in his throat, he was putting the cough assist on, and he was just pushing that food down into his lungs. And therefore, the cough assist was actually, at that moment, providing more of a hindrance than a help. So we really have to consider dysphagia and thinking about things like, when we use the cough assist device, if somebody's got dysphagia, we don't want to be using it after somebody's eaten, or even up to 1 to 2 hours after they've eaten, if they might have food sitting in their throat. Also, we might need to consider, for some people, if they really need that airway clearance, that we might need to think about other ways of them getting their nutrition. And that's where the whole team will come in. But this, for me, was a really interesting case study, in that you really have to think about what you're doing when you're giving somebody a machine, because it made no sense to me, the fact that he had more chest infections after being given the cough assist. And then, really importantly, when we're thinking about kind of points 3, 4, and 5 that I talked about, so can they use a device independently? What's their care support network, and how will it fit into their day-to-day life? We have to remember that the patient should always be at the heart of their care. So we need to be working out what their goals and wishes are of treatment. How can we make sure that our airway clearance and cough assist is fitting in with this? What are their priorities in this moment? And where does the cough assist and airway clearance fit into this? I think one thing that's really clear is, if it's not their priority, they're maybe not going to engage as much with the teaching and training. So it's making sure we're giving that device at the right time. We also need to think about the benefit versus burden of airway clearance, and making sure we're reducing that burden as much as possible. And as I've mentioned numerous times, their support network is so important. So when we're thinking about training, this was a study done in Australia, I'm pretty sure, in Canada. And they did telephone interviews with 28 cough assist users and their caregivers, in the aim to find out, what were the barriers and facilitators. And they did it with 14 established MIE users and 14 new MIE users. And they found, they kind of grouped the facilitators and barriers into these 4 groups. So initial educational needs. So many subjects identified these one-on-one education sessions, so either just with them or with their caregiver, that lasted 1 to 2 hours, with hands-on practice, a successful strategy for initiating home use of MIE. The patients really endorsed this personalised and interactive approach to training. They wanted the opportunity to be able to ask questions, and they wanted the opportunity to be able to practice using the device with somebody there to check that they're using it correctly. It was deemed as essential to be making sure that paid and family caregivers were trained for those that were unable to use the device themselves, which I think is quite obvious. And they wanted printed or video resources to supplement this training, to be able to go back to it afterwards. Some people, however, reported that they felt when they were trained that they didn't have sufficient instruction, and they felt this contributed to uncertainty in regarding the best technique for the use of the MIE. So, as I mentioned earlier, they talked about limited knowledge of methods for ordering device components, such as consumables like the mask, and also knowing who to contact. And also, a couple of people highlighted that they wanted better instruction on cleaning both the mask interface and the tubing. Follow-up education. So they describe, both patients and caregivers describe this follow-up education as a helpful reminder to use the device as instructed. They also liked that it was an opportunity to discuss early frustrations, and they felt that a discussion with the prescriber of the device was really helpful into kind of getting over these early frustrations, such as air leaks with the mask interface, or training other caregivers at home. And in terms of barriers around this, people often felt that if they didn't have this follow-up education, they felt like they'd been a little bit abandoned with the device. And then when we're thinking about perceptions of benefit, this was quite interesting for me. So people really wanted to know about the perceived benefit. So one person talked about how they had the flu at the beginning and they didn't know how they were going to feel, but they thought that the cough assist was really, really useful. And they used the phrase like, wow, this is really helping me already. Some of them talked about this favorable sensation of stretching their lungs. And so they were really keen to have this perceived benefit, which some of them then reported they didn't have because they maybe didn't have a chest infection right away. And interestingly, some wanted to know the impact of the cough assist on their respiratory function. And they felt that using the device may increase their FVC or their peak cough flow when tested by spirometry, which I think we know is probably not the case. But that was a really interesting finding. Also, ongoing use of MIE. So basically, they found the ones using it really incorporated it into pre-existing routines. They used reminders. So especially people with cognitive impairment, they use these reminders using things like their phone, and they found these really beneficial. And then in terms of the barriers to this, many of them found difficulty early on in the use. So this is another thing that's been highlighted numerous times, that actually it's really important to have these touch points early. They reported concerns when they were hospitalized, for example, people not being able to know how to use their device when they were in hospital, which is definitely something that is an issue in the UK. And they kind of summarized that insufficient education regarding the purpose of the cough assist, the technique and maintenance were the key barriers to its ongoing use. So I've just tried to summarize these here from what they found. So barriers were insufficient instructions, lack of early follow-up, not knowing the benefits of the impact, and portability of the device. So the device is quite heavy and people found that a bit of a challenge. Understanding the facilitators were understanding the reason for the device, this one-on-one training, this interactive hands-on training, early and regular follow-up, and the use of these daily reminders. And they put some recommendations out for clinical practice. So considering in the initial education, so providing one-on-one training, offering device demonstrations and hands-on practice, and using printed or video instructions. Follow-up education, so providing a telephone or at-home visit within the first few weeks to following device initiation. And then encouraging users and caregivers to set reminders for themselves to ensure they're using the device. And then continuing that education, so ensuring that adequate training on the MIE amongst hospital staff in case patients are admitted, and ensuring that you're giving that ongoing support as the patient continues their journey. So how can we improve practice? Firstly, I think we have to think about education for healthcare professionals around device prescription and suitability of a device. And I think we have to learn from what the patients are telling us about what they want from education as well. Research. So I think we need research into behaviours to support successful implementation. So Hov et al. Showed that MIE is often much more utilised in children rather than adults. I mean, why is this the case? Is this because the children have got a parent who is, really enforcing it? And we need to think about how we can use behaviour change interventions to support adherence and usage. We need to link in with industry so we can influence how these machines are developed and ensure that they're supporting the needs of healthcare professionals, patients and caregivers who are the main users. And considering adopting a co-design approach, so making sure we're getting patients telling us what they want from the device and healthcare professionals so that we can make sure that we're getting what we need as we go forward. And then training and skill acquisition. So this is both key to ensuring the patient has the training and skills to be able to use the device, and the carers have the skills and the knowledge to be able to support them with it. And so thinking about kind of training and skill acquisition, this is something that you can be seen on the device. So using the chameleon function to support this kind of training and skill acquisition of using the device with the patient. And this can be used when you're training the patient and the caregiver in what to look for them to be able to develop the skills to be able to use the device effectively. And there's a couple of references, and thank you all very much for listening.
Thank you very much, Charlotte, for your presentation. Is there any questions in the chat? So don't hesitate to put your in the chat in the box. I have some questions, so I will start maybe.
Mm-hmm.
I had a question about, let's say, training. You say that trust and confidence is one of the main themes reported by the patients and caregivers. So the question is, what could we do to increase confidence between the caregivers and the patient, and also between the users, so caregivers and physiotherapists, and the devices themselves, practically speaking?
Yeah, I think a lot of the trust and the confidence comes from the training itself, and ensuring that when we're training patients and caregivers on how to use the device, that we're giving them that kind of positive feedback. Yes, you're doing that correctly. Yes, that is correct. Or no, maybe change this, so that they can learn these skills, because it's a brand new skill for them to be able to do this. I think it also needs time and practice to develop the trust between the patient and the caregiver, if the caregiver is holding the mask on. And often a really good way I found to do that is just to get them practicing it when you're there with them. And I'll often say, oh, is your wife or husband or whoever holding the mask on as tightly as I did? And the patient will often say no. And then I say, okay, you need to push it on a bit more. And kind of, you're just giving them that opportunity to learn and develop those skills. And then the second question was trusting the device, was it? Marius, I think you've frozen. I'm going to answer that one anyway. Trusting the device. So I think that is something that, again, comes with time. Yeah, so, patients need to learn to trust this box that they've just been given that makes a funny noise and blows air in and out of their lungs. So, yeah, I think that's a really key part, is learning to trust the device. And again, I think that comes with time. I can see a question in the chat. Do I have a reference for the settings?
Marius, I think don't have connection, but do you have a reference for the settings, Charlotte?
For what do you mean? Do you mean, do I have a reference for what settings to put the device on? Oh, as in age, illness settings to start off with. No, and I think that Michelle Chatwin published an article a couple of years ago which gave some advice on how to consider starting settings. I would say, when my personal experience is that if somebody's got a bulbar impairment, you would want to start the settings much lower, with lower flows and lower pressures, and build them up. I always try and start the pressures a little bit lower for the first time I put it on the patient's face, just so that you don't scare them. We saw a kind of quote from one of the patients saying how they felt the first time it went on their face. And to go back to Marius's question, we have to build that trust with them. So I would say there isn't really anything that says, if you've got this illness, do this. If you've got this illness, do that. It very much depends on the patient. I think you're back now, Marius.
Sorry, Charlotte, I've been disconnected. I'm back. I had a question also regarding how we can implement a support for the patient. today there is no device allowing telemonitoring, so we are not able to get the data out of the device on a platform like we do with CPAP devices or NIV devices. What is your opinion about potential connected MIE devices in the future? We spoke about support network. You spoke about support network. So could telemonitoring increase patient follow-up, especially for those who struggle with adherence?
Yeah, I think that is a big thing for us to consider in the future. So I think that we know these patients are very physically disabled and they find it difficult to access hospitals or clinics or whatever. So if we can have the ability to be able to remotely monitor the cough assist, so whether that be things like adherence, things like leak that we look at in NIV, and also there's a bit of stuff coming out now looking at waveforms that can be downloaded from the devices and whether we can use those to assess the efficacy of the treatment. I think that is going to be something that's really important going forward. I think we're not there yet with the waveforms at the moment. Currently, there's only one device that can do that. And so therefore it's not widespread. But I think that's where, as I said on the last slide, we really need to partner with our industry partners and say, this is what we want. We want to be able to monitor remotely. We want to be able to see the waveforms. And I think there's a lot more research that needs to be done. Currently, nase endoscopy is the gold standard for assessing upper airway issues. So we need to have a think about, do the waveforms correlate with what we're seeing on nase endoscopy? And if they do, then, you know, being able to remotely download waveforms and assess them, I think will be hugely, hugely beneficial and hugely important to support care.
Yeah, sure. We definitely need more evidences, I suppose, I think, on the benefits, the added value of waveforms, for sure.
Yeah.
Someone is asking for research for paper regarding the settings you mentioned. Could you tell us more? Some kata,
is that Tina Anderson's paper? Is that the one? The one where I was talking about how you adapt the settings for bulbar impairment?
I think it was about bulbar impairment.
Yeah. So yeah, I can share a link to that paper if people would like. I probably can't get it right now and put it on the chat, but I don't know if there's a way for us to share a link to it afterwards, so people can have the flow diagram. Yeah, definitely.
Okay, thank you very much. Is there any other questions from the audience? Well, I guess we are done. Thank you very much, Charlotte, for your presentation tonight. Thank you, everyone, for being here today with us. I wish you the best, and you will receive the recording directly in your mailbox from the session. And thank you again, Charlotte, for being with us tonight. It was a pleasure.
Thank you. Thank you for inviting me.
Bye.